Hi, I'm Dr. Wu from the California Center for Reproductive Health. And today I want to talk about a topic that's confusing for a lot of patients, and this is PCOS, or Polycystic Ovary Syndrome. This is a really common diagnosis, and a lot of patients aren't sure whether they have it or they don't. So I'm just going to review some of the diagnostic criteria and why it's important to know and what you can do about it, okay? So the first question patients have, how is PCOS diagnosed and do I have it, okay? So there's actually a couple of different classifications for polycystic ovary syndrome. One is through the NIH, which is really a pretty loose diagnosis. There is another classification from the Androgen Excess and PCOS Society, and as you can tell, that is actually the most stringent classification for PCOS. I would say in general, the most widely used and widely accepted from OBGYNs and reproductive endocrinologists is the Rotterdam criteria, which came out in 2003, and it requires you to have 2 out of 3 requirements, okay? And I'll go through them each a little bit in more detail, but the 3 requirements are: 1, you have to have oligo-ovulation or anovulation, so essentially irregular periods. 2, signs of androgen excess, so male hormone excess, and this is either clinically, so you have physical signs, acne, hair growth, or you have biochemical signs, so blood work evidence of high male hormones, okay? And the 3rd one is PCO morphology in the ovaries when you do a transvaginal ultrasound, okay? So the first one, oligo or anovulation. So this, a normal menstrual cycle is between 21 and 35 days. So if your cycles fall out of that range, you have a little bit of an, we call irregular cycle then, right? So this is important because a lot of PCOS patients will actually have what they think is their period, bleeding maybe every 45, 50 days, and the bleeding is very heavy. It lasts for, over a week. And sometimes these are just breakthrough bleeding, and I always tell patients, just because you're having bleeding doesn't necessarily mean you actually released an egg this prior cycle. And that's important because, if you're trying to conceive, you have to release an egg to The second criteria is signs of androgen or male hormone excess, okay? I think the laboratory results are pretty evident. Clinical signs, I think, is a little trickier. You have to take into account, someone's ethnic backgrounds. So I think if you do notice that you have a lot of chin hair, facial hair, and you're plucking every day, talk to your gynecologist, because this could be something that is, more so than just your ethnic background, hair growth, okay? And then the 3rd one, PCO morphology of the ovaries. This one's a little tricky because a lot of young women have a lot of eggs. And so the diagnostic criteria of having more than 20 eggs in each ovary sometimes is just normal. The PCO really classic appearance on ultrasound is something called a pearl necklace, where all the little eggs are actually on the very edge of the ovary, and sometimes that can give us a clue. But I think, again, you need 2 out of the 3 of these criteria to meet the classification for PCOS for the diagnosis, because each of them on their own is not quite enough, and there's a lot of different things that can result in each one. So the diagnosis, I think, shouldn't be done from Google when you're looking things up. You should be seen by your OBGYN for an evaluation so that they can really tell you if you actually have PCOS. So I think the next question is, why is it so important for us to make a correct diagnosis of PCOS? And this is because there are actually more serious endocrine disorders that can have very similar symptoms and signs, and it kind of mimics PCOS. So you really do need to have a comprehensive workup to kind of rule out any of these other more serious illnesses to then make a correct diagnosis of PCOS. And then PCOS, having this diagnosis, is also important because it's also associated with kind of future more systemic illnesses like diabetes and heart disease. So if you do have a diagnosis of PCOS, you should be monitored for anything like prediabetes and cholesterol levels. So make sure that your family doctor, your gynecologist, is following you for that. So what should I do if I think I have PCOS? So again, this video is just for information. I think because I see so many patients kind of confused with this diagnosis, but this video is not meant to be diagnostic or treatment, you should see your OBGYN so that they can really do a thorough evaluation for you specifically and let you know if you have this diagnosis or not. And then depending on what you actually want to do, if you want to, if you're actually looking to conceive, or if you're just trying to help with alleviate some of the symptoms, or just have regular periods, your OBGYN will develop a treatment option and plan for you. So then the last question is, what if I have PCOS and irregular periods and I really want to get pregnant? What should I do? So again, start with your OBGYN, okay? They should be able to see you, start you on oral medications. So we have medications like letrozole, Clomid, and then if there's an indication, also metformin for women with PCOS that can help you really ovulate, to bring up an egg and release this egg, and then have you and your partner try. When should you see a reproductive endocrinologist? After your OBGYN has evaluated you and started you on this treatment plan, after 3 to 4 cycles where you've seen that you've ovulated, and you're still not pregnant, then you should consider coming to see one of us, because we might need to do a more thorough evaluation for you and your partner. And then also, REIs are trained so that we can actually give you more advanced technology, so injectable hormones to get you to ovulate, and also in vitro fertilization or IVF. So I think the trajectory should always be with your OBGYN first if you can, and then to follow up with us after 3 to 4 months if you're not pregnant. Thank you for listening. I hope this video was informative and that you were able to take something away about this really confusing topic for a lot of women. And if you have any more questions, feel free to reach out to the clinic to set up an appointment, and we can kind of look through your kind of individual situation and history in a little bit more detail. Okay, take care.